Hey everyone, it's Dr. Towfigh. Welcome to Hernia Talk Live, our weekly Q&A with our favorite people talking about everything related to hernias. Thanks for everyone who's joining me on Facebook Live at Dr. Towfigh and on our Zoom channel. And many of you are following me as well on Twitter and Instagram at HerniaDoc. Remember that at the end of this episode, this session and all previous sessions will be uploaded on my YouTube channel. So please welcome my guest today, Dr. Andrea Pakula. So Andrea is Director of Robotic Surgery. She's a very talented surgeon. She does a very wide range of hernia operations. You can follow her on Facebook at Andrea Pakula 7 and on Twitter at Andrea Pakula. So please welcome Dr. Pakula. Hey.
Hey, thank you so much for having me. Excited to be here.
I was going to say that even though you do so many other operations, you do bariatric surgery, trauma surgery, emergency general surgery, all the different surgical subspecialties, I think your love is hernia surgery.
Definitely passion of mine is hernia surgery. A lot of the complex stuff for sure.
And did that start in your training or it happened afterwards? Because for me, in residency, I had no interest, and then it happened afterwards.
It actually started in training because, as my residency, we were a busy trauma center. And with that led to a lot of big incisional hernias, or if bad traumas had left an open abdomen, which some people, have to have in order to get them through the traumatic injury, they were left with these giant hernias. So that was where my passion for hernias started, which was reconstructing the abdominal wall. And then it's just taken off from there.
Yeah, I know that I think trauma surgery is a #1 largest predictor of incisional hernias, and then colorectal surgery is #2. It all has to do with, emergency surgeries and maybe dirty or contaminated situations that give what's called incisional hernias. So you're in a very unique situation because you were trained pre-robotics. Is that correct?
Correct.
Like most of us. But you've taken on robotic surgery as not only part of your armamentarium, but you've really become one of the handful of leaders in the United States that really are very gifted in robotic surgery. You teach robotic surgery, you proctor it. I chose you because, first of all, I miss you. It's been a while since we've seen each other. It was a nice excuse to see you. But also there's just a handful of you all that really are champions of this technology. So when did you learn robotic surgery, and when did you have that aha moment of oh, well, this is even more interesting than laparoscopic surgery, which was really your main subspecialty?
Yeah, so I trained on the robot in 2016. And my initial reason for training was specifically for the complex abdominal wall hernias. I wanted to be able to offer minimally invasive approaches for some of these big hernias.
Yeah.
And going through the training and seeing the benefits of the surgery, whether it was for a hernia or a gallbladder or whatever it may be, that's what opened my eyes to, wow, this technology really is incredible what it's allowed us to do. And that changed me within a year. I was a full practice or total practice robotics. So now I pretty much approach almost everything that I can robotically.
No kidding. It's almost 100% robotic surgery. That's pretty impressive. And just to clarify, you're at Adventist Health, which is a private practice hospital, and you're in private practice.
Correct. Yes.
And don't you feel that private practitioners are actually more active and more gifted in many ways with robotic surgery than those that are employed in a university-based teaching hospital?
I do think that. I think sometimes when you're in a bigger university type hospital, you tend to, #1, have to focus on the specialty that you might be, hired for. And also, obviously, those are great hospitals. They're training institutions, and we have residents in those institutions, but they're not necessarily able to push the envelope and kind of perform outside of the box, if you will. And so it's been great being in private because I've been able to do a lot more.
And many don't know, but laparoscopic surgery started the same way. It was
Exactly.
mostly private practice doctors that took on the technology and started advancing it.
Mhm.
So this is, I think, number 88. I think this is episode 88 that we're doing. So
Wow.
we've been doing this almost 2 years. It's really great. And we do get questions about robotic surgery. Maybe you can help dispel some myths. Who's doing the operation? How autonomous is the robot? Let's start with that. And then how is it different from laparoscopic surgery? Because
Yep.
I often use the terms interchangeably, but I know that technically they're not the same.
Right. No, and I get asked that a lot in the office if I'm seeing a consultation. They'll say, well, who's actually going to do the surgery?
Yeah.
So the way that I talk about robotics is it's just really an evolution of minimally invasive surgery. It's the next best minimally invasive tool. So the surgeon themselves is doing the operation. I have complete control over the instrumentation. What makes it robotic really is just that I control the instruments somewhat remotely. I'm sitting, maybe over on the couch here where I'm controlling the instrumentation that's actually enabling me to do the procedure. But the difference is that it's so precise. The visualization is 3-dimensional versus 2-dimensional, which we see in standard laparoscopic procedures. The instruments literally articulate, so it mimics what we do open, whereas what we call traditional, we'll say laparoscopic surgery, those instruments they're like chopsticks. They don't have wrists at the end of them to be able to allow us to articulate. So that surgery or that ability with the robot makes the surgery more precise, less traumatic to the tissue, less bleeding, and overall less pain. And I really have seen a tremendous result with respect to faster recovery, need for really minimal, if any, narcotics at all, which has been really great for patients.
Yeah, that's one of the things that I think we didn't predict when we were doing robotic surgery, especially for the abdominal wall, is our colleagues that were starting to really push the envelope and use it for these big hernias, which definitely laparoscopically almost no one was doing. We were just doing them all open. And then they started doing it robotically. And whereas they would be in the hospital 3 to 5 days minimum, they would go home the next day. And when I started doing it, I was like, I didn't believe it, but I mean, I did believe it, but I was kind of, well, maybe it happened in some of their patients. No, like literally the next day, like, okay, can I go home? I'm like, yeah, you can.
Right.
Pretty amazing. Pretty amazing. So one of our questions is, how do you balance the advantage of robotic surgery versus the need to like do everything via an intra-abdominal approach, especially for hernia repairs or inguinal hernias? It's open approach, and then there's the extraperitoneal approach, which we do laparoscopically. But with the robot, everything you have to go in the belly first. What are your thoughts on that?
You don't. There are obviously a number of hernia repair techniques, and there's different accesses, as we might call it. So as you referred, or you refer to laparoscopic extraperitoneal approaches for inguinal, we do that for ventral as well. So we call it the eTEP, or the enhanced totally extraperitoneal approach.
Yes.
And I'm very selective as to, I take every patient as an individual, their hernia characteristics, the patient themselves, previous operations, and that's what helps to guide me as to what approach I think is going to be best for them. And then of course, images, maybe CAT scan images and things like that, but you don't have to enter the abdominal cavity. And I try to avoid that sometimes, depending on, what the situation is.
That's a really good point. So the eTEP, there's so many acronyms, first of all.
I know.
With hernias, TAPP, eTEP,
IPOM,
TAR,
right.
TAR up. There's all these. It's crazy. We actually published a paper on it. It's like
On
so
just
crazy.
the different acronyms. That's fine.
Yes, because we had to kind of get everything like somehow defined for everyone else. But yeah, originally everything was intra-abdominal.
Yeah.
And as leaders like you kind of started doing more and more, you started to say, oh, well, we don't have to do everything intraperitoneal. We can start making tissue planes. And so both for ventral hernias, so the abdominal wall in the middle, you can make those extraperitoneal, the lateral flank ones, and then also the groin. Now that said, it is actually a much larger space that you would make with the robot usually than you would with a laparoscope. Is that fair to say?
Well, I would say for, you're talking about staying extraperitoneal?
Yeah.
I think it depends. I mean, for like eTEP, for instance, for a ventral hernia, I didn't do eTEP laparoscopically. I did TEPs for inguinal hernia, but not for the ventral space. You can create a much larger space because the ease of dissection with the robot, it facilitates the ability to make a much larger space, but you don't have to. If you're doing a preperitoneal repair, which though we enter the abdomen, we are still placing at least our mesh outside of the abdominal cavity.
Yeah.
I think you can make as big a dissection laparoscopically. It's just harder. It's hard to dissect on the abdominal wall with those unwristed instruments.
Yeah, you're kind of you're like standing in the ground and like operating on the roof, on the ceiling. It's kind of weird. Yeah.
Exactly.
So then the follow-up question is, can you specifically address any benefits of robotic inguinal hernia repair versus, let's say, laparoscopic? Are there certain patient factors that play in your decision, or should patients be aware of like what things may or may not be in their favor to choose a robotic inguinal hernia repair?
So I will say you can do robotic, how can I answer it? So a TEP does not just mean laparoscopic. We can do robotic TEP inguinal hernias. We just call them eTEP because our ports are placed a little higher than usual. It's not in the same location.
E for extended.
Extended, exactly. For me, I'll be completely honest, I pretty much predominantly only will do robotic now. Now, whether I'm doing a TEP or a TAPP, it again depends on patient factors. So those factors would be if they have an associated ventral hernia, umbilical hernia, let's say, or even a big hernia that for me, I'm going to be in that extraperitoneal space or outside of the abdominal cavity, then I can extend it down into the groin to fix the inguinal hernias at the same time.
Yeah.
If it's an isolated inguinal hernia, I prefer to do through the abdomen, what we call a TAPP approach, because I can look at the other side. So if they don't have symptoms on the other side, we know that around 20% or so of patients will have a hernia on the other side that they don't even know about.
Mm-hmm.
And I can see it and I can fix it right then and there, rather than the TEP approach where you have to completely dissect out that space in order to identify the hernia on that other side. So that's a benefit, I think.
Yeah, I agree. And then, the whole open versus laparoscopic, that's just a different discussion, because if you need to have an open repair, then laparoscopic usually doesn't make a difference. That said, I've always said there's two main reasons why robotics is beneficial for surgeons to learn. One is, in general, for hernia surgery, laparoscopic has been a very difficult technique to master for multiple reasons. Anatomy is one of them, and just technique is a little bit more complicated. And the advent of robotic surgery has made it so that that learning curve has been improved. So there are papers that have said somewhere between 250 and 500 inguinal hernias need to be done laparoscopically before you start kind of stabilizing in terms of your outcomes. Mm-hmm. Whereas that number, I think, is down to like less than 100 for robotic surgery. So that's one benefit. I think more surgeons, from what I understand, are doing minimally invasive surgery and offering it to their patients. Even in our hospital, there are surgeons that never offered laparoscopic inguinals, and now with the robot are offering it, which I think is great because it's a better repair. Absolutely. And it's a shorter recovery. Laparoscopic or robotic.
Yeah, I completely agree.
But the other thing, and I used to be, I'll be very honest, I was a skeptic early on. I was very honest. It's like, why would you do anything robotic when you can do it laparoscopic? It's only for surgeons that don't know how to do laparoscopy. And I completely take that back, because the technology of robotics, and correct me if you want to add to that, is such that I can now do surgery operations I was doing open before, minimally invasively. So I was handicapped by the laparoscope, by the laparoscopic instruments, and could only offer certain operations open or
Mhm.
laparoscopic. But now a fraction of those open surgeries I can now do minimally invasively via the robot, whereas I couldn't before. That includes the TAR and these kind of like complex abdominal wall reconstructions.
Mhm.
And most recently includes what we call RIPT, the RIPT, the robotic iliopubic tract repair, which is a non-mesh tissue-based inguinal hernia repair, which really would be super difficult to do laparoscopically. So there's that too.
Yeah, I mean, the majority of surgeons that we are training now, I think, you know, we see so many that are converts. They're open to robotic, maybe
Mhm.
more so, like you said, maybe more so than laparoscopic to robotic. Although many of us, you know, may have done laparoscopy prior for some of these repairs, but so many surgeons can offer minimally invasive procedures now to their patients that they otherwise wouldn't have before.
So follow up to the last question is, are there any disadvantages to the more extensive dissection in the retrorectus space with the eTEP, because it's extended TEP, as opposed to regular TEP?
Yeah, I mean, you know, with respect to the eTEP approach and being in the retromuscular space or retrorectus space, and then taking that down into the groin, there's more chance if you're repairing a ventral hernia with or without an inguinal, when you're in that space, there's a chance that you're going to have hematoma because you're right on, you know, bare muscle.
Yeah.
There's a chance that that posterior layer, that, you know, that the layer that's covering the intra-abdominal contents, that if you happen to close that and there's too much tension, it can open up, leading to what we call an intraparietal hernia, where intestine can get into that space now, creating a bowel obstruction. So there's obviously nuances to the technique for us to avoid that. But that's the difference between, you know, that would be the disadvantage if you're doing a big dissection that you don't need. But if they have an associated ventral hernia, it's a really good repair to be able to take care of all of the hernia defects.
So you work very closely with Intuitive Surgical, which is the company that is the current producer of the Da Vinci robot. There's no real competition at this time for them. And you represent them in proctoring people and teaching and so on. What do you see? Do you see any concerns? One of my concerns, because I consider myself an educator, is through teaching laparoscopy, there's so many things that can go wrong. And you teach the residents and the fellows and, you know, how not to accidentally puncture a bowel or how to carefully manipulate things because your fingers aren't doing it. It's an instrument that's doing it that can be sharp or it can be hot. You can't really determine that. All you see is what you see and not everything else around you. So there are blind spots. My concern sometimes is that when people go from open to robotic and don't go through that laparoscopic learning curve, that maybe they don't appreciate the nuances of safety. What are your thoughts on that?
I think, I mean, twofold. I will say the majority of general surgeons will have some laparoscopic experience, I would think,
Okay.
with cholecystectomy, you know, gallbladders, appendectomies, even if it's
Yeah.
just the basic stuff. So they should have some degree of experience with laparoscopy.
Yeah.
But no doubt, open to robotic for inguinal hernia is very stressful when I'm proctoring,
Yeah.
because they're not necessarily familiar with that space. You know,
Right.
it's very different anatomy. There are very important structures down there, blood vessels. And so, but the nice thing is most surgeons will be pretty hesitant with
Okay.
their dissection and what they're grabbing because they know they don't know that space. And so I almost sometimes they're more careful than, and I don't want to say than they need to be, that's not right, but they're overly careful, you know what I mean? But no, absolutely. I mean, there's definitely a learning curve. And if you don't have an appreciation of, we can feel it laparoscopically. I do believe, though, that there is haptic feedback with the robot, but it's learned over time.
Yes. Yeah.
So, you know, it's just, I stress to them the need for being extra careful and really understanding the anatomy so that injuries don't occur.
Yeah. The other question that was presented was, if I have a choice between laparoscopic and robotic surgery, is there one that I should choose?
You know, I think it's just a discussion you need to have with your surgeon. I think that you obviously, for a surgeon, the best technique that they do is what they do best, if
Right.
that kind of makes sense. So if you go to somebody that's done hundreds of robotic cases and only a few laparoscopic, then I think you should have a robotic operation if that's what they're more comfortable with, and vice versa. And then, of course, I encourage all of my patients as well to research both. You know, robotic surgery is laparoscopic surgery. It's just, you know, again, it's just a finer, more precise technology to allow us to do it.
Yeah, I feel like there's very few situations where you would say, oh, definitely don't do it lap, or definitely don't do it robotic.
Right.
Yeah, very few situations like that. If robotic surgery allows greater precision and freedom of movement for the surgical instruments, why do they generally take longer? That's a question presented.
I'll kind of be blunt about that. It really depends on the surgeon and the skill set.
Yeah.
Early in your learning curve, absolutely, it's going to take you longer because you're learning a new technology. I am just as fast, if not faster now, with the majority of my robotic cases than laparoscopically. And I'm a skilled, you know, I consider myself a skilled laparoscopic surgeon. I did a lot of laparoscopy prior to robotics, but it doesn't always take longer. It often can be faster. The efficiency of your staff, your support staff in the room, and just your skill of doing the procedure.
Yeah, when I was a resident, laparoscopy, laparoscopic gallbladders were a thing.
Mm-hmm.
Laparoscopic appendectomy for appendicitis was not yet a thing. It was still like the attendings were doing them.
Mm-hmm.
And then laparoscopic hiatal hernia repairs like Nissen fundoplication also would be like a 2 attending thing. And as a resident, you just held the camera. There was not much that you would do because the attendings were in their learning curve. And it took forever.
Yeah.
And as the resident holding the camera, you like, why don't we just do this open? I don't understand.
Right.
And now those operations are done without even questioning whether we should do our appendix surgeries or Nissen fundoplications for hiatal hernias laparoscopically versus open. So I think understanding history and the evolution of new technology and finding the pros and cons of each and following that is very important. I get this, you know, I think administration focuses on that a lot. You know, took you this long to do your robotic surgery. And like, yeah, but the patient went home.
Right.
They don't have a wound infection. They have a better repair. So there's a lot to be said about that. Let's see, got some more questions here. Okay, this has come up a couple times. So I don't know if you're aware, there was this Netflix documentary called The Bleeding Edge. And in it, they talked about different FDA approved devices, including the robot, that had associated complications. And they did focus on the Da Vinci robot and the risks of complications with that. Specifically early on, I'm sure you know the history better than me. Early on, it was really initiated in gynecology, and there's a lot of risks of intestinal injury at the time. And there may have been a handful of, you know, instances where the robot kind of needed to be rebooted or got stuck or something. So can you talk about the dangers of the robot and what was it discussed at this documentary and how you can address that?
Yeah. No, it's a great question. So, you know, first and foremost, again, it's the surgeon that's doing the operation. It's not the robot.
Correct.
So complications can happen in any type of surgery, open, laparoscopic, robotic. And obviously we do our best not to have complications, but those complications specifically for the dehiscences and the gynecologic procedures,
Yeah.
I mean, I think that was really a technical problem. You know, it's not the fault of the robot. It's easy to blame the robot because, you know, the surgeon doesn't want to take blame. But if there is a failure in whatever it is that you're doing, it's a technical failure more commonly, not because the robot did anything wrong. So as far as safety goes, the robot is, again, it's very safe. There's so many almost fail safes, if you will, that, you know, if it's not going to do anything without me controlling it. If I grab onto something and I take my head out of the console, the instruments won't move. So there's even that level of safety. Let's say if you get into bleeding, you can control it very quickly, very easily. But for hernia surgery, I mean, it is very safe. Like I said, I do pretty much all of my hernia repairs now, short of the hernias that I really can't do on the robot. I do them robotically. So it's really the safety is of the surgeon and what we do. It's not the robot doing anything or causing any undue, harm or unsafe practices, if that makes sense.
That's true. And we actually published our paper on the safety of, I do a lot of mesh removal from inguinals, and it's tricky because the bladder's there, the nerves are there,
Vessels are
the
there.
major vessels to your leg are there, and the spermatic cord in males and its associated vessels and the vas deferens, which is all there. So we looked at the laparoscopic way of doing it versus the robotic way. Now, fortunately, everyone did well. So outcomes were basically the same. However, you had less bleeding and less injury to these major vessels, like the big vessels that go to your leg, with the robot. And probably that's related to the high precision and the visualization. And even if we did get into bleeding, that it was easier to control. But yeah, there's definitely that. Again, I would say, look at history. So when gallbladder surgery came about, you probably know this story. Actually, to this day, I think it's still true that injuries to the bile ducts is much higher with laparoscopic surgery than with open surgery, even to this day. And when laparoscopic cholecystectomy came out, there was one paper that showed this like multiple fold increase in bile duct injuries and so on. And these surgeons who were advocating for laparoscopic surgery in the gallbladder were, I mean, there's stories, where they had like literally tomatoes and eggs thrown at them.
Right.
And they were booted out of some meetings. They weren't allowed to present. It was a lot. There were campaigns to prevent laparoscopy. So understanding that even with laparoscopy, which right now we think definitely it's very safe to undergo for gallbladder surgery, it still was not considered safer than open. And a lot of it was surgeon related. It was like surgical technique and understanding the pros and cons of and your limitations with this technology. If you do robotic inguinal hernia repair, not the eTEP, so we're talking TAPP most likely, can you fixate the mesh with either tacks or suture to Cooper's ligament without causing postoperative chronic pain? Or is the Cooper's ligament a very sensitive site for fixation? That's a good question.
Yeah, it's a very good question. So, well, first of all, I will say the beauty of the robot is that we've eliminated tacks.
Yes, thank you.
Yes. Especially, I mean, I'll talk about the inguinal to answer the question, but I mean, in the ventral space, the tacks that we used to put up there were so painful to patients. And I mean, we would take patients back just to remove tacks out of specific areas that may have hit a nerve that we couldn't see. So,
and why did we even invent tacks? Because we couldn't suture laparoscopically.
Exactly.
So it was trying to make up for the deficiency of laparoscopic surgery, which the robot took back because it's more like doing open surgery.
Right. Absolutely.
I love it.
So for inguinal, I suture the mesh to Cooper's ligament, like you asked. Cooper's ligament is I can speak from my own patient experience. There's not an increase in pain. I think the ligament itself does fine to take sutures without causing any risk of pain. Now we try not to suture into the bone, causing osteitis or inflammation of the bone itself. That can probably lead to some increased pain, but we try to be specific as we're placing those sutures. I don't place personally any other sutures. I only suture to Cooper's. I don't like to place them on the abdominal wall because the nerves are so variable in their distribution that even though we see the main trunks of the nerves and we try to visualize those during the operation, there are other little branches that we can't necessarily see. And I'm always concerned that a suture will potentially grab one of those. So I place sutures to Cooper's with not worrying about an increased risk necessarily of pain because we just don't see it there. You see
Yeah, that's a
something different?
big point that I feel like robot kind of takes us back to more original surgery, more classic surgery, more open surgery, but with the addition of extra technology. It is a very expensive technology though, I must say. But everyone seems to be okay with it now. I don't know. I feel like, I mean, you have a community hospital. We have 9. I think
Wow.
10. Actually, we're going up to 10
Well, but
robots.
Intuitive has done very well at making it easier to get a robot in the hospital. You don't have to put that big capital lump sum purchase. They have leasing programs, they have rental programs, they have pay as you use programs. And the more you use, the more it pays for itself. So hospitals want to be able to offer it because they want surgeons to come that are going to be able to do it. And then obviously they want to promote it because they want it to pay for itself. So ultimately,
Yeah.
It's expensive, but I think they've come up with ways to get around that.
Yeah, and I'm advocating bringing one of our robots to our surgery center because most of what I do is outpatient. There are certain patients that can have their prostate surgery or other kind of more complex operations in an outpatient surgery center. COVID has made it so that it's really not feasible to do simple elective surgeries in the hospital setting when you have other sicker patients that take priority. So yeah, we tried to do that back in 2014, maybe, 2014, I think. We tried to get a robot and it was just too expensive and didn't make any sense. But now with better financing and the fact that we have 10 in the hospital.
Yeah, that's incredible.
Yeah, we're hoping to get one because for me, it would be such a game changer to be able to do all these in the outpatient surgery center. Super excited about that.
Yeah.
On that note, there was a discussion on herniatalk.com, which is our free discussion forum that we have for everyone about cost. So specifically, if you're a patient, talking about the patient standpoint, I know that the robot is expensive to acquire, but from a patient standpoint, does it cost more to have robotic surgery?
The short answer is no.
Yeah.
I'll answer it in two different ways. So insurance, with respect to when we submit for a surgery, whether it's laparoscopic or robotic, it's the same code. So there's no increased cost to the robot.
Yeah.
The hospital doesn't cost more, doesn't have an upcharge for robotic, and the surgery center does not either. Now, if you're a cash pay, and you probably can answer this better than me, but if you're a cash pay patient, then yes, it could be more expensive if you're going to do it in like for me, I don't also have a robot in the surgery center. So if a cash pay patient and I say we'll do it on the robot and it's going to be done in the hospital versus I'll do it laparoscopically in the surgery center, it's going to be less expensive for them in the surgery center because of just the overhead costs. But robotic itself, if you have insurance, is exactly the same.
Yeah, just to clarify on that too, it's done by code. So there is no robotic code yet. And so you can't tell the insurance we're going to charge you more because they're like, well, it's the same code. So what are you talking about?
Right.
Even though it may be more expensive for the hospital. A lot of people don't understand, like, how could it be more expensive for the hospital and yet not charge the patients the same? And that's kind of our screwy system of insurances and how things are paid for. But yeah, it goes by code. With regard to cash, I've had really good luck with cash quotes, even at the hospital. And we have we're considered kind of an expensive hospital to have cash pay patients in, but they've been really good about it. So I think even with cash, they don't tend to dump a lot of the cost on the patient. They're just more volume based and they're hoping to capture it based on that. Let's see. Next question. After inguinal mesh removal with the robot as opposed to laparoscopic mesh removal, and I was talking about inguinals, but I don't know if this question is about inguinals. Yes, it is about inguinals. Okay, so after inguinal mesh removal with the robot as opposed to laparoscopic mesh removal, does the site of the original hernia become weaker? Does the removal leave a void such that at the original hernia site? Do you do much mesh removals?
I do.
Yeah.
For both ventral and inguinal.
Yeah.
I do a lot of recurrent hernias, and so
yeah,
it depends on why I'm removing the mesh. But yeah, I I know you do a lot of primary, tissue-based repair, and you're probably going to disagree with what I'm about to say a little bit, although
We'll see.
yeah, the majority of hernia repairs, it is, we'll say ventral for anyways, standard repairs with mesh. We know that recurrence is lower with a mesh versus a tissue-based repair in the ventral space. Inguinal, if you do a really good tissue-based repair, you can have good recurrence, low recurrence rates. But if you're removing a mesh, I think absolutely wherever that is, the tissue is going to be weaker and it's definitely going to be prone to recurrence.
Yeah.
If you don't do any, even if you do some sort of a primary repair after you've removed it, the tissue, is going to be weaker, scarred, and prone to a recurrence.
Yeah, that's very true. So with one exception, if you're removing infected mesh, there's such a huge inflammatory response to that often, especially in the groin, when the hernias aren't that as big as those in the abdominal wall, that huge amount of inflammation, often you can't see anything. So you just take out the infected mesh and deal with the infection. And in my experience, about 20% of them at about 2 years or later will get a hernia. But the majority actually don't. It's just such a huge scar response. However, if you're removing mesh because there's a recurrence or there's pain or whatever, you will have a hernia there. And then the question is always, okay, now what do I do? So if I remove the mesh because the mesh was balled up, I'll put mesh in there again, because that would be the most appropriate treatment, assuming the patient agrees to that plan. But if I'm removing the mesh because they're somehow reacting to the mesh, or the mesh itself is the problem, then a tissue-based repair is indicated. What you don't want to do is remove the mesh and don't do anything, because you'll just have a rip-roaring hernia immediately. Unless every so often I see a patient like, I didn't even know I had a hernia.
Right.
They just went in there that you did, and they put some, and it was really small, let's say. So if it was so small that it was found incidentally and someone put mesh in that caused pain, then potentially you can remove that and you can't really see a hernia to repair. And maybe in those occasions, I'd say, okay, let's take it out, see how you do, understand that it's very possible you'll get a hernia again, and then we'll deal with repairing it at that time. But yeah, the scar tissue from regular mesh repair is not strong enough to prevent a hernia repair once the mesh is removed. That we learned. Someone's asking you where you're from. I think they mean like, where do you practice, not like where you're actually from.
I'm from Southern California, and I practice in Simi Valley, which is in Southern California.
Are you from Southern California? I didn't know that.
I'm from Chino Hills.
Oh, nice. Okay, so you're local.
I'm local. I know. I'm back closer to home from.
That's great.
But yeah, I'm here in Simi Valley, which is
excellent. Okay, next question. I need a hernia repair surgery, and I'm in so much pain right now I could puke or cry. Let's see. Umbilical hernia is what she has right now. It's just a tissue repair without mesh. So yeah, you can have pain from a tissue repair. Do you want to address that a little bit?
Yeah, I mean,
belly button.
Yeah. So one of the things I use, and I'll still do the occasional open umbilical hernia repair.
Yeah.
And if it's very tiny, not place mesh. When I say very tiny, I'm talking 1 centimeter, my fingertip. We know that anything larger typically will do better with mesh. Probably, and I obviously can't say for sure without seeing her, but what happens sometimes when people do an open repair or tissue repair, they don't fully identify the incarcerated fat, the preperitoneal fat ball that basically gets stuck in there. And if you've closed that and that fat is stuck in there, that can cause a lot of pain because that fat has no real good blood supply. And that seems to be a common reason, I think, for pain after primary repair. If it's a small umbilical that, you can have a little suture, abscess or granuloma. You can have, unlikely that nerves were gotten in a tiny little repair, but I suppose
not a nerve issue.
Yeah, more likely it's probably missed incarcerated fat is what I find when I take these patients back.
Yeah, or it's just too tight of a repair.
Too
You know,
tight.
they're trying to cinch down something larger than 1 or 1.5 centimeters,
Mhm.
or the patient is like obese and there's already a lot of tension there
Tension.
anyway, and you're trying to really cinch that close. So the pain you're feeling is actually the sutures tearing through your muscle. And unfortunately, the result of that is a bigger hernia,
Mhm.
in which case you definitely do need mesh in the repair. Let's see, next question I had. Oh, this one, this was someone who actually sent me this question on YouTube as well. I'd like you to answer it. So it's a patient who talked about, where's the question? Oh, I'm going to ask it. So this is a patient who had an open inguinal hernia repair with mesh, let's say Liechtenstein repair, and then they had a wound infection.
Mm.
And then now, so that's been treated, but the wound never heals. So the surgeon wants to now remove their mesh. What are your thoughts on that?
So open Liechtenstein with mesh, wound infection, the wound never healed.
Correct.
I mean, if you have mesh infections in the groin are extremely problematic. And in my opinion, in my experience, if you don't remove the mesh, it's not going to heal. So I would say probably do an open excision and removal of that mesh. Leave it alone, let everything heal. And if and when they recur, I would go in and do a posterior repair or a robotic repair, assuming they are fully clear of their infection.
Yeah, I mean, there's so many factors in not healing a wound, but if it was already infected and looks like it's E. coli was a bacteria, and you have some foreign body, it could be a suture or it could be your mesh, depends. That can be a nidus of infection that prevents you from healing. So even if you don't have pus or drainage or anything that tells you it's infected, that mesh may be chronically infected. I've noticed in those patients also, they're just not healthy. They kind of feel sick still, they're fatigued, some may have joint pain or headaches and just tired. And then you take out their infected mesh or their mesh that is chronically infected, and they're like, oh, I feel so much better.
Right.
But it's because you don't see like a pus and like an active infection, but it's a very low grade chronic infection that will prevent you from healing. So I know it's a big deal to take out groin mesh. Fortunately, less of a big deal in infected situations because everything's kind of like mushy anyway. But yeah, you kind of have to, if you're not healing, infection is definitely top on the list of why you're not healing. Going back to the question about pain, it could be like a early recurrence or a missed little hernia in the belly button. What imaging would you order to help figure that out?
So for any abdominal wall, so not inguinal, and yeah, I'm not a huge fan of ultrasound for ventral abdominal wall hernias. I would get a CT scan, non-contrast CT. It allows me to see if there's a hernia recurrence. It allows me to see if there's any fat within the defect that was repaired.
Yeah.
We can often see mesh if there was mesh in there. And then it also helps me to plan how I'm going to do the repair if I'm planning to bring the patient back to the operating room.
Yeah, it's very simple. I think in the United States, CT scan is so much more readily available than a good ultrasound. Often you do get ultrasound and it gives you no information at all.
Right. And it's very dependent, right? It's dependent on who's doing the ultrasound and who's interpreting it, just like CT scan. But we read our own CT scans, so.
Right, exactly. But outside the US, they tend to be more reliant on ultrasound and they're usually better at it. I think they just do it more and see more. And then there are a handful of places around the US where they're really good at hernia ultrasounds. I have one guy, he's older and he's a radiologist. He does his own hernia ultrasounds, like himself. It's not like a tech does it and they read it. And he talks to the patient, he moves them around. It's awesome.
That's great.
Like, you cannot retire because it's, sometimes you don't have to get like an ultrasound, a CT scan if you have a good ultrasonographer, but it's far. Yeah, it's usually hard in the United States. We don't have good ultrasonography. Okay, next question. I had an inguinal hernia repair 5 years ago, and I'm still in a lot of pain. What can be done? Ooh, that's a big question.
Well, I mean, I would ask, did the pain ever go away or did it come back? Is it the same type of pain?
Yeah.
Because it could be that a hernia was missed, right? We've missed femoral hernias have been missed, direct hernias might have been missed, or a cord lipoma, which is fat along the spermatic vessels and spermatocord. It could be a different type of pain, maybe related to a nerve injury or mesh related pain. So what you could do is, I would start with a really good physical exam and obviously a history, as I was just alluding to with those questions. And then if I felt that there was a need for imaging, then obviously we'd go to imaging.
Yeah, for sure. I think the story is the most important. When did it start? What makes it worse? If they say, oh, I actually had this pain before the hernia repair and I still have it. Well, then it wasn't your hernia. It was something else.
Right.
Or I was fine 5 years ago. For 4 years, I was fine. Now this year I have problems. Well, that's a recurrence usually.
Right.
You don't have hernia related complications that occur years later, with the exception of maybe a weird infection. But so on that note, you mentioned cord lipoma. Can you explain what that is and why you think that may cause pain?
Yeah. So basically, in men in particular, this is how I describe it to patients to get them to understand it. So, your testicles are obviously in utero, they're up near your kidneys and they descend, as you know, through a ring, which is called the internal ring. And with that, there's fat in that area that can track along the path that your testicle takes. Females can get lipomas as well. It's just a little bit different. But basically, fat can track along the spermatic cord and the blood vessels to the testicle. And that can act as a hernia in the sense that you have a ball of fat within the, usually within the scrotal area. And so patients will feel that bulge. So if you have that, but no actual hernia defect is recognized, it doesn't mean that you don't have a hernia. So it's important for us as surgeons to make sure that we look for that lipoma and we get it out of there, because if we don't, and we just place mesh and we do a beautiful quote repair, but have left that, your symptoms are going to be unchanged. And so that's a big part of a hernia repair for
there are some surgeons that say, lipomas don't hurt. But I think I'm trying to argue why it does hurt. I think what's happening is at the time of the hernia, right? These things are moving in and out or whatever, or pinching. But once you fix the hernia, and if you left the lipoma in place, you've now closed the door on it. Right. And you trap this fat in a limited space. And that's where maybe the pain comes. I don't know if that's the right answer, but I'm kind of trying to logically figure out why the lipomas hurt. Of course, it's occupying a space that should not be occupied. So whatever's nearby. Sometimes people get nerve pain, right?
That's what I was going to say. There's nerves that run along the cord, so absolutely that can contribute to the pain.
What bugs me is they get nerve pain, and they go see a doctor, and they're like, "Oh, you have nerve pain." They do nerve injections and nerve blocks, and I've seen people have been told that they need a neurectomy, spinal stimulator. All they had is a hernia.
Right. Well, and
yes. Nerve entrapment. Oh, it must be nerve entrapment.
No, and it's it's very important also when I'm talking to somebody that's got groin pain, whether they've had a hernia repair or not, for them to understand that the back and the hip and the groin are very intimately related. So a hernia is the easiest thing to fix, right? Having a hip replacement or back surgery, not as easy. Us taking you for a known hernia and fixing that is fine. But if something persists and you don't have a recurrence, you don't have a retained, cord lipoma or what have you, or there's no mesh issue, then the other things need to be investigated, because potentially that is the cause of the problem. And I've seen that where it's like, oh, you know what? Yeah, I needed a hip replacement. So I'll
Very
send
true.
that to. So
it's so true. A labral tear or bursitis or something. We have had a couple different really great orthopedic surgeons on where we discussed kind of how hip problems and orthopedic problems can cause groin pain, and it's so important to like have that visualization. What I tell the patients is, you don't just wake up one day and your nerve gets entrapped. Like that doesn't happen. Now, if someone stabbed you in the nerve, okay, I can understand that. But short of that, that just doesn't happen.
Yeah.
So I don't understand the logic when people are taking down this whole nerve pain pathway when all they needed was a hernia repair. Going back to the lipoma question, can you get the lipoma out robotically without widening and traumatizing the deep ring? These are great questions.
I know. Well, it's a good question. So if you've had a repair and it was done laparoscopic or robotic and the mesh is there, we have to take down that mesh in order to get to the lipoma. And it can be done, absolutely can be done. But no, you can't just get to the lipoma without taking that flap down again, getting that mesh out of the way and going in. You're not necessarily traumatizing the ring, but you have to get through the previous repair. Now, if it was done open previously, then no, it's not anything different. Now you're just going from behind.
Yeah.
Or if it was done posteriorly previously, then you can go open just to look for the cord lipoma. How do you like these?
Yeah, well, I think the question is just the act of removing a lipoma that may be large. Does that in and of itself stretch out the area or cause damage?
Yeah, no, I mean, we've pulled some really large lipomas out. It doesn't I don't think it distorts or disrupts the ring. It's not supposed to be there. It's in that fat's not supposed to be there. So that being there is more probably disruptive to the ring than us removing it.
Yeah, I agree. It doesn't. I mean, muscles stretch. So we're good. Yeah. We're not injuring the muscle. Going back to the gentleman who probably has a mesh infection and is being told that he needs his groin mesh removed. How dangerous is that? What are the likelihood of like him being maimed or having major complications from it?
So I know this was open, done open.
Yeah.
There's going back and doing any sort of redo in a plane that has already been operated on, obviously is going to have a little bit more risk for potential injury because the area is scarred. So it's going to be more difficult to identify the nerves potentially. There are some vessels, obviously, not like doing it robotically or laparoscopically. It's a little different, but I would say nerve injury can happen. If you're not able to identify the nerves, depending on where that mesh or what type of mesh, you said Liechtenstein, but if a plug was placed or anything else was placed, now we're talking about a mesh that's deep inside that could be attached to blood vessels and, other things. So it can be obviously risky, as long as it's just the hopefully it's known where the mesh is and the surgeon understands,
Yeah, it's so important to know your anatomy and that, although hernia repair is considered such an easy operation, the anatomy is one of the more difficult areas of the body. Absolutely. And you have urologists that work there and gynecologists that work in that region and nearby orthopedic surgeons and general surgeons, and none of us really master any of it.
Yeah.
I work a lot with them. So one of the things I love about what I do is I do operate with these other specialists and I get to see like their train of thought, their approach, their techniques. It's really nice to work with other specialties. I really like that part of what I do. Okay, someone just joined and said, I have a miniature basketball size umbilical hernia. I'm supposed to have robotic surgery. What are the chances of damage to the intestine with this approach? I'm all of a sudden freaking out because my hernia is so huge.
Mini basketball, like those little hoops that you have in the office?
I think those Nerf ones, yeah.
Well, again, I think it's important. I don't think that whether it's laparoscopic or robotic, the biggest risk, I guess, for injury is going to be entry into the abdominal cavity. And there are a number of ways that we do that so that we're careful so that we avoid injury. Doing it robotically does not necessarily mean you're going to have a higher risk of injury.
Right.
The important thing is that the surgeon understand, they're going to give you a good repair. So if there's actually, this is something we didn't touch on, but you may have a basketball sized bulge, right, of intestine or fat that's coming into that defect, but the hernia itself could be much smaller. And vice versa. It could be a very large defect that has a bulge. So understanding the different techniques as to how to repair it is what is more important, I think, to make sure that you have a good repair. The risk of injury, though it's there, is extremely, extremely low. You know, we have to be very careful, obviously, and make sure that we're not injuring anything, either on entry or in reducing the intestine that's stuck in the hernia. But these risks are very low.
It's really, you know, I feel that it's very technique and surgeon dependent. The surgeon with the light touch open probably has a light touch laparoscopically, and vice versa. You can injure bowel with open surgery. There's so much to kind of, you know, I also say this about all these mesh lawsuits. You know, there's so many mesh companies are being sued, whereas if you look at it, like the surgeon used the wrong mesh or put the wrong technique, or those were complications induced by the surgeon, not because of the mesh itself. So surgeon technique is very important. Do you have any tips on how they should find the right surgeon? Do you think they should ask certain questions? I always say they should have at least 50% of their practice should be hernias to be considered like a specialist.
Right.
Otherwise, you're a general surgeon.
No, I agree. I think if you're looking specifically for hernia, you can do just that. You can Google hernia specialist. You can look at reviews if they have them. You can talk to other patients that may have had surgery by that surgeon. And, you know, just because you go see a surgeon for a consultation doesn't mean that has to be the surgeon that you're going to have operate. So come with questions.
True.
You know, the more informed you are and the more questions that the surgeon is asked and can answer can help you decide if it's the right person for you, or right surgeon for you. But, you know, I encourage everybody to do their research, you know, on the surgeon and the different hernia repair techniques. I like it when they come to me with a whole list of questions, you know? Yeah,
I totally agree with that. Mostly because, I mean, you like it because you enjoy what you do. Some surgeons get pissed off at it, and that's like I think that's a red flag, right? Yeah, move on to the next surgeon that really loves what they do and is excited to help clear up answers for you. And I feel that I see a lot of patients that just fly or do telehealth or something because they got one answer and now they just want a second opinion, which is totally fine. You know, run. And I always ask them, who'd you see and what did they tell you? And I'll try and give you my perspective. I'll be like, oh yeah, I totally agree. That's absolutely what I would do. Or here are other choices for your repair. My concern is these people that have just a little umbilical hernia or just a little inguinal hernia, don't do their research. And then now they're in trouble. Yeah. Okay, going back to the gentleman who's had 5 years of pain, when they had their inguinal hernia repair, the pain then after the surgery is the same as it is now. He feels a lot of pressure, stabbing, and finding it hard to stand tall, especially in the morning. Oh, interesting. Was this laparoscopic surgery? I don't remember. Depends on the type of hernia. We don't know what type of hernia repair.
Right.
I would assume it's a mesh repair, but I don't know if it was a laparoscopic or open.
The pressure and stabbing obviously leads you to think that it's either, well, that's hard to say without asking more questions, but, and it was there prior.
No, it was there since immediately after the surgery, not before the surgery.
The same as it was directly after repair.
Yeah.
Okay. So, I mean, again, I think that either laparoscopic, he's responding.
Oh, okay. Laparoscopic, okay. Great.
So laparoscopic. So I would say it's either potentially that the mesh is folded. We've seen that where patients will come with I'm going to say laparoscopic, but it could be robotic. It's the same, minimally invasive repair. That they have issues with bending or sitting or folding, you know, and that could be from mesh having folded, causing some discomfort. If it was a shooting, you know, burning type pain, obviously we worry about nerve injury. But if it's pressure specific to a point, I think that could be due to a mesh related problem. But again, the first thing that I would rule out is a recurrence and or missed hernia, because it happens,
Yeah.
maybe the dissection wasn't big enough to expose the femoral or direct or a cord lipoma and all of those things. So
Yeah.
it really is, this can be dealt with. We would need a good exam and obviously a number of other questions that we would be asking and potentially some imaging.
This clue of finding it hard to stand tall, I feel sometimes the mesh is put in too taut in the beginning. So it's not following the contour of the pelvis, but it's kind of tight. And then as we know, mesh also shrinks a little bit after surgery. So now it's even tighter. And so they feel like they're being pulled in, or they can't hyperextend or kind of do a lot of their normal activities. And you can't really loosen up those meshes. You have to just redo it. But if you have imaging and it doesn't show what you said, which was a hernia recurrence or a balling up of the mesh, then sometimes it's too tight of a mesh. And it just kind of needs to be redone. That's one thing that I've seen before.
Yeah.
Can you believe it? We have a whole hour that's gone already.
This has been great.
Unbelievable.
I mean,
right?
Questions. Yeah.
You want to join me again next week? Let's do this every week.
Let's do it every week. Oh, this has been a lot of fun.
Yeah, it's been a lot of fun. Thank you so much for your time. I really appreciate it. You're busy. You're still at the office. You got this awesome thing in the back. Someone congratulates you, Dr. Pakula, Master Surgeon. Is that your publication?
My office staff did that. There were balloons and everything else in here. This was a while back. They put this board together for Master Surgery. It was kind of fun. So.
Oh, that's so awesome. Thank you so much. Well, thank you for your time. You're great. I hope to see you in person pretty soon. Are you going to come to Costa Rica?
So I'm not sure. I was considering it. April. I'm in Florida because it's in April, right?
Yeah, first week of April.
So yeah, so I'm in Florida for Connect that week.
Yes.
And then I'm in Iowa also doing some robotic speaking thing in Iowa in April. So I haven't quite figured out if I'm going to be able to get to Costa Rica. I haven't ruled it out yet.
All right. Well, we'll be there waiting for you.
I know. I've been talking about it though. I would love to go.
Okay, a lot of great conferences coming up, and I hope to see you at all of them. So thank you, everyone. Thank Dr. Pakula for her time, and I will see you again next week. We have another great guest. I can't wait to discuss more topics, and we have some great stuff coming up in the future as well. Thank you for your time. Thanks for everyone for joining, and such great enlightening questions. I enjoyed all of it. See you all next week.
Stay healthy and safe.
Yes, thank you.